call her.
Once she comes, anyways, she's taking some time for the people to hear.
Start 5 minutes. Ears and eyes. Handing access for. Start? Okay. All right. Hi, everyone. Can I ask you to settle down, please? Everybody who's in this area, can you please settle down? Hello, everyone. Welcome to our Community Connect session today on community-led test and treat advocacy and community engagement approaches, including lessons from COVID-19 in India and Zimbabwe. My name is Karishma, and I represent an organization called FIND, which is a global non-profit organization that strives to improve equitable access to reliable diagnosis around the world. The session today has been co-organized in collaboration with Unitaid. So before I introduce my co-chair and the rest of the speakers, I'd just like to share a quick background on this project. So it was during the COVID-19 pandemic, and you may have heard of the ACT Accelerator, also known as ACT A, or the Access to COVID-19 Tools Accelerator, which was set up with the goal of speeding up production and equitable access to COVID-19 diagnostics, treatments, and vaccines. So FIND was co-leading the diagnostics pillar of ACT-A, and Unitaid was co-leading the therapeutics pillar. And as these important vaccines, diagnostics, and treatments were being made available, we also realized that there were numerous challenges in making these equitably available to people in need. And so we set up this project where we saw and we thought that there was a real need for context-specific advocacy strategies. And we conceptualized this test and treat project. We had about $2 million US dollars available in funding. And we ran a request for proposals, and we had a lot of engagement. Over 300 people applied, organizations applied. And in the end, we selected 21 organizations from 19 low and middle income countries. And today, 3 of these organizations are present with us. And we have the opportunity to learn from them on how they applied these advocacy strategies and whether some of the learnings can also be extended to TB. So I'll just hand over now to Smilka from Unitaid, who's co-chairing the session.
Thank you, Karishma, and thank you so much, everyone, for joining us and not eating too much into time that we have actually for the speakers. I wanted to just bring one point and just unpacking a little bit the intention behind the small grants. As Unitaid, we have been doing this across our TB portfolio, so investments in both preventive TB across 21 countries, also pediatric, and now we're exploring this for TB diagnostics. But the beauty of the small grants is really to facilitate the fact that we have such a vibrant, strong, important community on the ground that with a certain amount of financial resources can actually really go a long way across so many different dimensions. especially in terms of advocacy, which was very important in test and treat work, community engagement and increasing demand for services, health literacy as well. But I also want to bring one point, which is around capacity development and organizational development that we also were hoping to achieve with this small grant. So I wanted to unpack a little bit the concept. We have tested in TB, launched it in COVID, and now we are bringing it back from COVID to even more fine-tune what we are doing in TB, and that's why this session is so valuable for us. Thank you.
Thank you, Smilka. And with that, we will introduce the first speaker, Diptendu Bhattacharya, who is a TB and COVID survivor and advocate. And a very special thank you to you for stepping in. I know that it was Chappal who was supposed to deliver this talk and he wasn't able to make it to the conference. So thanks once again for speaking on behalf of PI Consulting and Survivors Against TB. So you can make your way to the mic.
Good afternoon, everyone. Myself, Diptendu Bhattacharya. I am a MDR TB and COVID-19 survivor, and I come from India. And my background is I am a biotechnologist by my education, and I teaches microbiology at college level. Since time is short, so I directly come to the presentation which is given to me. So the as our chair already briefed about that project, I will not take much time to repeat all those words again. Just to say that about some few words about Survivors Against TB. Survivors Against TB is a patient-led initiative. We are all the patients under the guidance of PI Consulting have come together and built up an advocacy network which works in double-ended. Like one side is talking with the policymakers, with the all those who have the power to eradicate the disease from the face of earth, and on the other side we are continuously communicating with the patients whose demands, whose needs the policymakers need to heart. So in this project, our objective was that to build a political will and public awareness on the both end, so that this COVID-19 testing and treatment can be strengthened and take the lesson forward to treat other diseases such as TB, which I have also been fought with. So what we have found from this project we are working on, which I was part also as a patient and a survivor of the disease, is that the main thing is that the the policy making sides are not guided by all the scientific evidence, but rather it is on the case per needed basis it is working, and the community is always at the side. Whenever the community's interaction is needed, then only community is invoked, and other time the policy is running on its own. Like one example is that when the pandemic started, there was a rapid democratization of testing. But when the pandemic goes down, that testing facilities, the whole infrastructure which has built up in a rapid pace in 2 years was also going down along with that. And it's like we are just making, we are preparing for a temporary thing, not a permanent thing. We could have learned that setup and use that setup to move India's goal to eradicate TB by 2025. It's a 2023 end, second last month. So if our goal is to eradicate TB by 2025, we have some same amount of urgency around TB also, but it is not shown in the public sphere. And the information and misinformation around testing is also, and treatment is also untreated. Many many ascientific solutions of the disease came forward during this period, which was popularly collected from the market and distributed and sold without any further testing of the materials. And communities' access to the informations, proper informations, and community-led structures was absent. And stigmatization is a main problem that which barred the people to access all those facilities, all those stuffs already available. So our initiative was, as I previously told, was both-ended. One side, we have worked with the media, print media, live television media, internet, and voiced our opinion around this disease, around how the ground rate is going on. Our publications has been covered through India Today and other scroll and other websites and other published magazines. Also, on the other hand, we have communicated through our TV Pe Charcha programs, initiatives, and COVID and learning initiatives for the patient side to aware patients about what is right to demand, because we believe that if we don't demand sufficiently, we don't get sufficiently, and and it goes like an Ouroboros loop. Once a policy is made, then policies flaws had come out. Patient says that it is not correct, then policies again change, again some flaws come up, and this goes around and around like Ouroboros loops. So we can't let it happen again. So we must be aware what is our need so that we can demand correctly. So the main challenge around this, and again I said that the political engagement and the key stakeholders are not currently engaging sufficient enough to rebuild or to remain the infrastructure as strong as possible. It is just like being a self-congratulatory that we have eradicated the disease, but not the same way it can happen in future. And also we can take this thing forward to other diseases like tuberculosis, so that we can have the similar result which we have seen for COVID in coming 2 years as per target. So on the final note, so my lessons and learnings from this project was that advocacy should be a continuous and equitable process. The political stakeholders must be always at their always at the feet, and must provide what the community has needed. And media's capacity has been built, as said, it should be expanded further enough, and delays cannot be tolerated anymore. And the misinformation and stigma should be challenged by our communities and the policymakers and the stakeholders, all the stakeholders equally, with equal might. Thank you.
Thank you so much for that. And our next speaker is Vikas Panibatla, who is the Chief Executive of TB Alert India.
Can I operate it from here? Yeah, thank you. A very good afternoon, everyone. My name is Vikas. I work for TB Alert India. It is an Indian entity of TB Alert, which is in UK, which was started in 2004. And the onset, I would like to thank United and FIND for taking such innovative program of giving small grants, which have proved that few things which are uncovered, which are unseen, can be worked out. So, and this project was implemented with GCTA, Global Coalition for TB Advocates. They are sort of a soul of the program as well. Without them, we could not have achieved. And we named this project as Fortifying Action for COVID-19 and TB. And we, in short form, we call it as FACT. In fact, it is a FACT where TB and COVID amalgamation was done. These are some of the unique aspects of this project, where we have nourished around C19 ambassadors. These C-19 ambassadors we call are people who had suffered with TB and they also got COVID. Having experienced both the diseases, we thought that they'll be able to work effectively towards advocacy and patient benefit. And also we have got C-19 ambassadors from various marginalized and underserved community like people, men having sex with men, sex workers, women and other people. And we have, as I said, like we have integrated C-19 into the existing community structures and self-help groups as well towards moving towards the sustainability thing. And intensified awareness campaigns were taken about by these COVID-19s. Further, there are certain animations in my presentation. If something goes wrong, please excuse me. These are the key. This project mainly has three strategies. One is empower, to build a cadre of C-19, COVID-19 survivors. I'm sorry, it should be ambassadors to support the project. And the second concept is educate, to create awareness about COVID-19 testing and treatment services and create linkages. And thirdly was to advocate, to enhance awareness and need for increasing the testing and treatment services for COVID-19. So these are the basic objectives of these three main strategies of the project. So now I'll go one by one what we have covered in each strategy. In Empower strategy, with the support of GCTA, we have developed a COVID-19 training manual, COVID-19 ambassadors manual. It is a manual which covers the basics about COVID-19, what are the advocacy and counseling requirement for TB patients, and it prepares like COVID being a new disease, it prepares them how to work with the communities on the COVID thing. And as you can see here, there's a latest updates of TB counseling skills and tools to understand the attitude of COVID-19 were some of the key curriculums. We have trained around 53 and 15 in 2 rounds. We have and the COVID-19 block includes, as you can see, 22 women leaders, 8 people, MSM people, PLHIVs, 9, 2 are female sex workers and 6 migrants. All of these people had TB as well as COVID. So we covered from all the various vulnerable groups coming in, and this is one of the training program we had. And the key achievements here, some of these achievements here, these COVID-19 ambassadors have reached out 402 awareness meetings, and 4,654 people were referred for testing and 1,061 were reached for testing. And the second one, educate, consists of 2 components. One is on the social media engagement. We hired an agency for this, and developing IC materials for the project. So these are some of the social media activities which were taken up as the projects, like giving opinion ads and drafting of the placements, interactions with the key personals and the COVID-19 ambassadors, and a lot of social media engagement was done. These are some of the social media posts which were developed as part of the project. And these are some of the IEC materials which were developed and which were also translated into the local languages which can be used. The third most important component was advocate. Here we have used a strategy of integrating COVID into the existing community groups like women's self-help groups, youth groups, local NGOs, and also with the forming local coordination committees with the health authorities, which also includes COVID ambassadors. The second point, as I was telling, is including it in the existing community structures. And third one is to conduct a lot of seminars, focus group discussions, sensitizing meetings involving key opinion leaders. And the last one is stakeholder consultations. Below you can see we had formed 5 local coordination committee meetings, integrated COVID into the 78 local existing community structures, 153 opinion leaders were sensitized and engaged, and 2 media coverages and 5 stakeholder consultations were done. So these are some of the experiences shared by some of our COVID-19 ambassadors who speak about, in a term like COVID having been lost, the focus of the country, how they have worked out for the project is something their experiences, and some of they also speak about their commitment to work for both COVID and TB. Thank you very much, and thanks very much for giving this opportunity. Thanks.
Thank you so much, Vikas. And our last speaker is Tapiwanashe Kujinga, Director of the Pan-African Treatment Access Movement, Zimbabwe.
So good afternoon to you all. As Karishma said, I'm the director of the Pan-African Treatment Access Movement based in Zimbabwe, and I'll give you a brief of our project in Zimbabwe. I have no conflict of interest to report on. So in Zimbabwe, our COVID pandemic started in March 2020, and then we had 3 major waves, which actually caused quite a lot of mortality, morbidity, and there were lockdowns, and it actually resulted in the need for civil society response. If you remember, most of you who are here will remember the early years of HIV and AIDS, when we actually thought that necessitated a purely medical response. But then later we realized that civil society was supposed to be an integral component of the response. So we responded to the pandemic through a range of activities, and with community mobilization, education and awareness, and a whole lot of other interventions. And we were, PATAM, my organization, was also involved in educating civil society organizations and mobilizing them through webinars and providing technical support to various government efforts in Zimbabwe and beyond. And in 2021, we received a grant from FIND, which enabled us to train nurses on using the nasal antigen detecting swab, for COVID-19. And one of the reasons was that there was a lot of hesitation on the part of communities, because the nasopharyngeal swab was very unfriendly. So we realized when that new swab came out that we could actually accelerate testing through making it available. And we trained nurses and other health workers in 3 provinces in Zimbabwe, and we immediately saw an increase in the testing numbers, which was very encouraging indeed. So 2022, we also received this grant for test and treat, thanks to FIND and to UNITAID. And our main objective was to mobilize civil society in Zimbabwe so that civil society could work together in addressing some of the gaps in COVID testing and treatment. We realized that the response in Zimbabwe was not very homogeneous. In other words, you will find that there were different testing strategies, there were different follow-up strategies, contact tracing, and treatment. You find people being given a lot of antibiotics for what was basically a viral disease. And so we had a meeting with the Minister of Health. We discussed some of the issues that were being reported from the various health centers in the provinces. And thereafter, we designed a training curriculum for civil society. And we held trainings in 9 provinces. We were supposed to hold a 10th one in another province. But unfortunately, the political situation in Zimbabwe can be a bit volatile at times, and it becomes very difficult to operate a civil society. But before that, we held a community survey where we collected data on the lived experiences of communities, where we wanted to find out realistically what is happening on the ground. Is testing available? Is contact tracing being done? Are the health workers available to roll out the treatment and so forth? And the findings of that survey helped to frame the approach, because we then could identify the gaps in service delivery. We could identify the gaps in testing and in treatment, as well as the other components in terms of availability of equipment and materials, as well as availability of health workers. I mean, right now, or in the last 2 years, Zimbabwe has lost a lot of health workers to, to the UK, to other countries. So it has actually created a gap. So we actually had, those meetings, and they helped civil society to really understand what the issues were. We realized that there was an awareness gap within civil society, and we tried as much as possible. Unfortunately, we couldn't master as many members in the trainings as we would have wanted to, but it actually helped civil society to be aware of exactly what the COVID-19 response entailed and how they can work with their communities, to educate their communities, to link them to care, to monitor services, and to ensure that the test and treat component was actually fulfilled in our health system. So, what did we learn? Civil society and communities have an integral role to play in pandemic preparedness and response. I mean, we learned during the HIV pandemic that communities should not be victims. Communities should be stakeholders. They should be equal partners at the table, because civil society and communities can actually do sometimes what health systems cannot do. So once there's a pandemic, then civil society needs to really understand the nature of the pandemic, the structure of the response, and the niche which it is supposed to fill. And secondly, the response should be informed by evidence, knowledge, and collaboration between civil society organizations at national and international levels. Like I said, in Zimbabwe, COVID-19 patients were actually being given antibiotics. And, our point was, you cannot give antibiotics to people who have got a viral infection. And we pointed out that had the capacity to drive antimicrobial resistance. So we could say this because we do have the information in terms of what is driving antimicrobial resistance at both local and global levels. And again, communities should not wait to be invited. In fact, if a pandemic happens, then communities should immediately come to the response, because the government won't call them, the policymakers won't call them. They have to claim that space. And it is also very necessary that communities be empowered on technical aspects of pandemic response, data governance, disease policy, and cutting-edge response, among other issues. So one of the things that, there's two things that we are working on going forward as an organization. The first one is data governance, because data sometimes is generated and it's supposed to be used by communities in their response, but sometimes that data is not available to communities, and it is important that communities should own the data and they should use it in a way that they deem fit. And the second thing that we've done is we've now gone ahead to broaden our approach on diagnostics, because previously we have been focused on diagnostics at the disease level, whether it's HIV, TB, malaria, or COVID-19. But together with the O'Neill Center for National and Global Health Law, we've created what is called the Diagnostics Equity Consortium, and we are working to scale up access to essential diagnostics at, in low and middle income countries. So thank you so much for your attention. Over to you.
Thank you so much. And maybe we can stay on this one. I really like this summary as well. And that I'm actually first, let me first thank you, and then also open maybe to some questions from the audience, if there are any. And yeah, I'm gonna bring, fantastic, thank you.
I think I have two questions. I guess one of the things I think is important is it's good to see the results of the work that has been done around this, but how is it being repurposed and moving forward I know, what are some of the challenges you're seeing to keeping these things going in the long term? And is there any potential solutions that you may see or can suggest to make sure that things just don't get updated, don't fall through the cracks, can be utilized more broadly and for other things? Because it seems like amazing resources that have been created and a lot of work has been done. So just, yeah, questions on that.
Hello. Yeah, thank you very much for question, and in fact, a very important question, I should say. See, the purpose of the grant is it's a small grant program which is funded, and it is intended to piloting certain initiatives. So our program was mostly included on creating a new innovation sort of thing where not a disease specific ambassador, but one who is having already experience. We wanted to leverage on that. And that is a major component which we have piloted it. Towards the long-term sustainability, we focus mostly on the grassroots level because we were working with the local community members, local community groups. So we have integrated these COVID ambassadors into these groups and also sensitize those groups also to speak about COVID, not to neglect COVID, because now the guard is off of COVID. People take it very light. In that sense, we have sensitized all these local level women self-help groups or men having sex with men groups to take this as serious and keep reminding to that. These were the two components which we did in keeping in the community sustainability and long-term vision into it. And moreover, the most important, all the COVID ambassadors whom we have found were already working as advocates or champions. So we have included COVID in their agenda as well. So they are taking forward the agenda. But to some extent, some more resources might be required to make it at a higher level, say at the policy level. Some more time and some more resources might be required to take it. Within the small gap of 1 year, we could do this, and we look forward to take this forward. And this was implemented in our intervention areas where we were doing. So any of the projects which we are implementing will definitely have a look on this. How this is going on is something which we have planned. Thank you very much.
Thank you so much for that question. I think it's a very important question. Sometimes we implement and we just leave things there. But for us, there's a number of sustainable or sustainability actions which we've taken. The first one is that we've realized that this is not the last pandemic. So, globally there's this vibe around pandemic preparedness and response, and we are very much involved in that because we want to ensure that when the next pandemic rolls in, the communities are ready. We don't want to be taken by surprise. So we are framing, we are part of the global process of framing, the civil society response to the next pandemic. But what we've also said is that we're actually in the middle of another pandemic right now, the antimicrobial resistance pandemic, right? 4.5 million or 4.95 million people dying annually, from resistant pathogens. So we actually need to start focusing on that. And that's what we are actually pushing right now. And the second thing is, as I said, we are also looking at scaling up testing. And this program was very pertinent because testing is the pathway, right, or the entry point to treatment and care. And many times, like in low and middle income countries, testing is neglected. So we want to make sure that, the testing capacity is there. The testing capacity can be scaled up, when the pandemic hits, rather than, for countries to start mobilizing for, preparedness, when people are already sick and people are dying. Thank you.
Okay, thank you so much for the powerful presentations. Mine is as much as a civil society, we are call ourselves innovative, but sometimes we are pushed by what is on the ground. For now, the buzzword everywhere is community-led monitoring. Community-led monitoring, that's the buzzword. And everyone is fighting to be part of community-led monitoring. So looking at the conclusions, I am saying, where is pandemic preparedness in this community-led monitoring mantra? We are talking of research, we are talking of data governance, we are talking, all those is evidence, knowledge, whatever. As we are pushing the community-led monitoring, there's platforms and so forth, where can this pandemic preparedness also come in? Where does this AMR come in so that we don't work in silos? We are working in silos, but at the end of the day, community-led monitoring, we want to understand everything. Or some are calling it now citizen science. Where are we? So that we don't work in silos. For example, now platforms. We have a platform for TB. We have a platform for HIV. We have a platform for malaria. So we are going to develop another platform for MR. We are going to take all these issues. But remember, we are responding to one person. It's me. I'm HIV, I'm a TB survivor, I have MMR, all those issues and so forth. So as these discussions are going on, can we prepare also how to put all these issues, emerging issues, into this community-led monitoring? That's the buzzword. And people are abandoning other programs. Everything is rushing about community-led monitoring, but we are working in silos. Thank you.
Oh, that's another very pertinent question, and thank you so much for that. So, community-led monitoring is actually meant to collect data and information at the ground level, right? So, monitors will actually go like to the health facility level, they can go even to the community level, collect evidence and data. And that data is actually then supposed to be upscaled to the policy level, right? Community-led monitoring is not an end in itself, it's a means to an end. So what ideally should happen then is to identify the gaps at the community level, and then those gaps are then addressed at the policy level, or they can be addressed at the advocacy level. So in terms of pandemic preparedness, right, I can actually simply put that in our issues of, right, communities, sorry, there's somewhere where I talked about evidence, right? Oh, number two, the response should be informed by evidence. So what that means is that our organizations should actually be coordinated in a way that that evidence, right, can then be pulled and then used for advocacy. Unfortunately, sometimes what happens is that that evidence simply goes back to UNAIDS, or it goes back to paper, or it goes to government. It's not coming to civil society, right? I also talked about data governance. Who is in charge of that data? Think about it, right? So, at country level, there's community-led monitoring for sometimes for TB, sometimes for HIV. And that either goes to the government or it goes to the donor. But who's got control over it, right? So data governance is something that we've realized is really critical, because if the monitor comes and discovers that there is a gap, right? Sometimes testing is not adequate. There are no reagents. Where is that reported? And where it's reported, is there any feedback? Is there any action taken? That data belongs to the communities, right? That information belongs to the communities so that the communities can actually take action. So community-led monitoring is just a cog within the whole broad response. And I think it's something that, you know, I think I agree with you, it's something that we really need to look at. Make sure that it actually becomes part of the civil society response rather than being donor-driven or government-driven. Thank you.
wonder if we're looking here at part of the inequity of availability and practice regarding COVID vaccines between the North and the South. What I'm conscious of, my question to you is, how are you geared up for continuing programs of vaccination against COVID? And I ask that question as being an older generation person living in London, I'm considered as being in a risk group. And as such, I am being called by the British NHS, National Health Service, for a COVID vaccine about every 6 months in order to be up to date with a vaccine dealing with the latest variant of the COVID bug. And is that being replicated in Zimbabwe and India? What's happening in terms of continuing vaccinations after the first one or two? I think I've had 5 COVID vaccinations so far. But I'm not sure when I start talking with people from Africa and India and even Eastern Europe, they look a bit bemused when I tell them that. Now, what I'm interested in is your programs. Are they capable of repeating the exercise? Are you geared up? Is the funding there to do additional vaccinations? Or is it just not happening anyway because of the inequity of the systems?
Actually, rightly you have pointed out that there is a deficit of awareness. Definitely, in India there was an optional third vaccine, but since the awareness goes down and people are thinking that it is already we have conquered the disease, so the medicines are stocked up in facilities where once upon a time there was a queue. That medicines are less and people's are more. Now the situation is flipped. Another dosage is available, but people are not interested in that. So that created lack of demand, influencing the next generation, lack of research. Since the demand is not there, so there is no further demand for research, further demand for development. So it going to going like a tadpole's tail, like it is vanishing, and day by day we are not hearing anything about these things, any vaccines or anything. But the yes, yes, that's the work we are doing, that to aware those patients to demand the thing, so that the lesson continues. One thing I have learned from my knowledge of history of medicine, that uh, this is not the last time we are seeing this kind of coronavirus. Already in 2003, 2004 we have seen the COVID-1. Then this is SARS-CoV-2, that SARS outbreak. That time it was called SARS outbreak. Influenza, Spanish influenza, 1918. That has been repeated in 2011 as avian flu, swine flu. So every time this disease will come back and hit the world hard. But we are not getting ready for that. Even we have to, if we have to wait for the next pandemic for some 50 years, 100 years, we don't know. But robust system, robust system, that will like we don't see plague anymore. Black Death, we have already did good job on that. Because of we have installed a robust system throughout the world, so that we are ready, we are always prepared for that. Same thing we have to replicate. We know how to do that because since we have done already, that means we know how to do that. Our political will, our financial, and all the stuffs should be come to club together and make a big hammer, so that we can cross the disease, and all the opportunities come out it's out of its outbreak in future. Thank you.
Uh, just one, adding to what my friend Dipendu has said, there's a role from the government side as well. When the pandemic was on peak, government literally in India had spoken about COVID. When we made a call, we used to get a COVID, COVID precautionary measures as well. Suddenly, the hype from the government has also gone down. Literally, it also led to the removing of the testing and the vaccination things. So what in our project, what we focused was people have started taking COVID very lightly. They started thinking it is just like a flu sort of thing. We need to take some antibiotics and some paracetamol tablets. It will be setting in. So one major focus which we did was creating awareness on the vaccination. And as part of the program which we did, we also motivated certain number of people to also to get vaccinated for things. So a little bit shift, which was mostly on treat and test and treat. We also expanded it to into vaccinate sort of component where we created some awareness and motivated people to go forward. But I feel like there was a huge hype and then a small down about the COVID at the government level as well. So they should keep the focus running on to do this. Otherwise, we start referring people and the availability is not there, then it also adds to a problem over there. Thank you very much.
Thank you very much for this very enriching discussion. So I'd like to ask each of you if we can leave with any one thought, comment, or reflection from the project. Maybe we can start with Diptendu and then move this way.
The main objective of this project was to strengthen the activism around the demand for the test and treat. So my take on this that we have done many, but not up to the not that much what we need to do the right what we need to take out the right outcome from the initiative. We have to continue this in future.
So for me, I think it's important that communities and civil society organizations should always be part of any response to any pandemic. And it is, they are a very critical stakeholder. I can say without hesitation that we won the HIV and AIDS war. If it had been left to the medical world, right now we'd be struggling with numbers on treatment. But now we've got universal test and treat. And that was a victory for civil society. And for any pandemic, civil society needs to be at the center. Civil society needs to be engaged and involved and make sure that their issues are addressed and their issues are also part of the broader response. Thank you.
I would like to say this is a start and there's a lot more to do and we have to do it. And a holistic approach of bringing all together is required. It might be the government, the donors, the community, and the ambassadors whom we are talking. A more holistic sort of approach is required to work on this. Thank you very much.
Thank you. Can we please have a round of applause for our speakers? Thanks so much.